Professor Cook is still Professor Cook. Okay, Professor Cook is Australian physio and very experienced in the tendinopathy management. Okay, you can say it's empirical on tendon. Okay, it can be painful. It can be no function. Okay, it can be very pathological on the tendon. You knew that it can be three of them. Sorry, it will be very, very painful and no function. And it is a lot of pathology inside. Okay? But some patient full function, but no pain. Pathology not that bad. Alright? Some patient got pathology, no pain. Pathology, no pain. Still good function. Okay? But those are degenerated. No pain can rupture. Okay? So you knew some tendon which is prone to rupture. Okay? So you knew that some kinds of Achilles tendon rupturing. Okay? They don't have any kind of pain before. Okay? And sudden loaded, oh, pop, that's it. Okay? So those are the pathological tendon without pain, without loss of function, but suddenly get loaded and then can rupture. If the patient is getting relatively more painful, that means the inflammatory sign right there. And the inflammatory sign is a good sign in terms of what? Huh? In terms of notifying you to control the pain or notifying control the load, and also inflammatory sign is a good sign of repair. Very good. Okay, so it attempt to repair, but although might be not very fruitful, okay, but still attempting to repair. So those tendon may not rupture or lower chance to get rupture. All right. So if they got this, you knew that some of the tendon portion is degenerated, but some of the portion is reactive, but it can be normal. Then what you want to do, okay, relatively newer. Okay, I'm not saying the 2009 is wrong, but a few years later on, Professor Koch got a kind of adjustment, okay, on the theory of tendinopathy. So you knew that ideally you want to go back to normal tendon, but this is too ideal, okay? Right now, you knew that the tendon, if you go for kinds of intervention on pain, you get the tendon no pain, which is green, no pain. Okay? But what? Degenerated and poor function. Okay? So the very green line is right here. You got good function. No pain, but you have to get intervention addressing the low capacity, which is function. All right, so low capacity. Remember this term, okay? Low capacity. That means your tendon can load well, or the tendon cannot load appropriately. Even small loading or tiny little loading can make you irritable. Okay, so that is the tendon not good in low capacity. All right. So then, if you want to go for kind of function, get rid of pain, but the tendon is still degenerated. You cannot reverse it, just like 秦始皇. Okay, right? Okay, it's not 長生. Okay, you cannot go back. Okay, you cannot go back. So you knew that the pathology is right there, but you can shift the pathology. No, okay, but you can shift the function better. All right, get rid of this going that way. Okay, no pain. But remember, if you go further, too aggressive loading, and tendon will rupture. So you're addressing the tendon capacity or low capacity. Got that? Okay. So for For tendon, okay, because why I want to put it right here, because I guess karate sensei is the coach of karate. Okay, the master karate. Okay, master karate master sensei. Okay, sensei 的先生老师一样。Okay. So it's a true case as well. Okay, so got inferior heel pain for 4 months, easel steps, got discomfort, able to drop pain, have further, and at the point of want to have her first marathon racing. Okay, tendons on palpation and calcaneus. Medial typical. Medial typical just means the insertion of medial typical of calcaneus. Insertion of what? Plantar fascia, right? Okay, so very typical, right? Okay. Early morning pain, right? Tenderness over typical. Plantar fascia, just like this. Insertion, right? So underneath the fascia, if you cut the fascia, you can see the deep muscles inside. All right, so you can double check on the muscles. So click on it and then study plantar fascia like this, okay? And then Rena's test is a test for kinds of plantar fascia tightness. Okay, if it's very inflammatory, a lot of kinds of inflammatory side or kinds of pain, then you might get a pain. Okay, but the definitely is not the only test for you to check on the plantar fascia. All right, but you can learn on it. Easy. Okay. You knew that the wear foot on the inferior heel pain can be the plantar fascia. Also what? You knew that we touched on the taping, right? Okay, not only the plantar fascia, you might think about the fat patch contusion. Why I choose sensei? Because when they do karate, they wear the shoes or not?
No.
Yay, this is it. All right, but they do a lot of this and then whatever. Okay, the bump is actually good. So why not coexisting? Why not coexisting? True problem. All right, so you might double check on fracture. You must double check on nerve entrapment, tarsal tunnel syndrome, as I already mentioned. Bursitis. Sorry. Tarsal tunnel syndrome is the tarsal tunnel, the nerve right here is trapped, so that's why you feel discomfort along the kind of numbness or pins and needles or something like that. All right, so what you can help? On this case, try to deload it. Okay, if you do a lot of exercises, yes, you might help. Okay, you do a lot of stretching, that will help. Okay, but why I have to put it right here, because the Achilles tendon and also the plantar fascia is interconnected. Okay, so right here the Achilles tendon go inside the calcaneus, and then if you know that it's actually a continuum going there, right? All right, so actually you treat the plantar fascia, you treat the Achilles tendon as well. Okay, if you want to treat the fascia, you don't want to irritate the plantar fascia, you treat that. All right, so any tension right there, up, going, lifting up. Okay, the calcaneus will do what? We do like that. Yay. Okay, so roll up superiorly. Okay, or actually got kinds of going away from the plantar fascia, so it got extra what? Extra tension. So it's easy. It's exactly the same principle. Okay, if you knew that it's a continuum. All right. So if you got the plantar fascia problem, okay, you don't have to work on too much on the fascia. You just save it, gentle stretch it. Okay, but do a lot of calf stretch. That will help a lot. Okay, but remember, in case for this patient is relatively kind of sensitive to touch or pressure with the problem on the fat pad, then what is the stretching technique you will choose? Huh? Yes, okay. Rather than this. Okay? Because positions is the matter, right? knew that. Yeah. Okay, tendinopathy, you can click on it and know a bit more. Okay, you knew that this is still tendinopathy. Still apply this principle of what Professor told you. Okay, but remember when on the posterior ankle, or sorry, the heel around here, not only the tendon, okay, but also what? Also the ritual calcaneal bursa. Ritual calcaneal is posterior to the calcaneus. Okay, bursa. Okay, subcutaneous calcaneal bursa right here. Okay, and also they got the fat head right here. Okay, so differentiate them. Okay, how to do the differentiation on the tendon versus bursa.
Change the length of the tendon and then palpate to see if there is any change.
Ah, smart guy. Okay, it can be. Okay, but what we can do is ultrasound imaging. Golden chance to utilize the technique. Right. Hard to tell. Yes, you can. Whenever you put the kind of change the name, okay, so you can do the palpation. Still might be kinds of very simple pain. Yeah, although you got a little bit more tension on it. Rupture is another issue, so that's why you still have to screen any kinds of potential rupture on the tendon. You do the squeeze test on the calf, which is the Thompson test, which is easy. Okay.